Hello, everyone. I'm Kordo Saeed. I'm a consultant clinical microbiologist and an honorary associate professor from Southampton, UK. And together with my co-chair, Professor Silvano Esposito. Silvano, would you like to introduce yourself, please?
Yes, I'm Silvano Esposito. I am the chair of the working group named Bone and Skin and Soft Tissue Infection by ISAC, which is the International Society of Antimicrobial Agents and Chemotherapy. And we were working in the last 12 years as a group, and we produced 5 papers on hot topics on bone and skin soft tissue infection. This is a good opportunity to, with this webinar, to restart, because we interrupted our work in the last couple of years because of pandemic, and so welcome to all of you.
Great. So we welcome you again, and please send your questions through the question function, which should be on the right-hand side of your screen. And also we would like to thank ISAC Secretariat, especially Fee Johnston, for her support in organizing this webinar. So with that, it gives me a great pleasure to introduce our first speaker, Dr. Monica Chan, an infectious diseases specialist from Singapore, who would be talking about non-tuberculous mycobacterial bone and joint infection. Monica, over to you, please.
Can I start? Okay, hi everyone. Thank you so much to the organizers, to Dr. Kordo and Professor Silvano. I'm very privileged to be here to speak at this webinar, and I'll be starting off the session with NTM, prosthetic joint infection. My name is Dr. Monica Chan. I'm a senior consultant for the Department of Infectious Diseases. I'm from National Center for Infectious Diseases at Tan Tock Seng Hospital in Singapore. So perhaps just to kick off the session, I'm just going to share a previous many years ago case of mine. So I have an 83-year-old lady, past medical history. She had hyperlipidemia, hypertension. She had a prior sigmoid carcinoma with previous operation. She had pretty much 4 joint replacements. So 2009, she had a right total hip replacement. 2010, she had a left total hip replacement. 2011, a left total knee. In 2013, she had a right total knee replacement. 2 months after her right TKR, she presents with 1 month of right knee pain. So on the 16th of April 2013, which is the X-ray on the left, was about 1 month after her initial operation. And you can see on the right, on the 4th of May 2013, is the X-ray about 2 months later. On examination, there was cellulitis over the wound. The distal portion was discharging pus and it was tender. So it's a long history, but I will try and compress it. So she had her TKR on the 8th of March. About 2 months later, at week 8, on the 4th of May, she had right knee pain for 1 month with redness and discharge for several days. On the 6th of May, the same orthopedic surgeon took her back into the OR operating theater, where she underwent a right knee debridement, synovectomy, explant of the TKR. At that time, just routine bacterial cultures were sent. The tissue and synovium bacterial cultures were negative. She had a cement spacer inserted, which had tobramycin and vancomycin. And then antibiotics were started after the operation, which was vancomycin and oral ciprofloxacin. Following that, she was unwell. She had fevers. Her inflammatory markers did not improve. Her ciprofloxacin was then switched to IV meropenem. She underwent a further right knee debridement on the 21st of May, which was at week 10. And this time, because this is the second debridement, they sent it for fungal cultures as well as mycobacterial cultures. And from there, the AFB smear was 2+, and the AFB cultures actually grew mycobacterium abscesses. After the results came out, about 1 to 2 weeks later, she was switched to IV cefoxitin for 2 months, along with the oral clarithromycin. On 27th of May, she had further debridements done. She had another washout of a joint, exchange of cement spacer because, again, she did not improve as expected. And she also had a vac dressing change as well. Finally, on the 31st of March, things seemed to be improving. She had a right knee debridement, further vac changes along the way. And 14th of June, she had finally had a split skin graft. So this was the initial cultures. So it was all very perplexing for all of us because she had an obvious sinus and she obviously had a pyogenic infection, PJI. And that was the initial cultures. And you can see here on the second operation that there were multiple cultures all growing the same organism. So the AFB smear was a 2+. And then from the mycobacterial laboratory, it grew mycobacterial abscesses. Also here is the antibiotic susceptibility. Quite typical of those found in Singapore. It was sensitive to clarithromycin and intermediate to amikacin and cefoxitin and resistant to the others that were tested on the panel. So more pictures. So this is the X-ray on the 16th of April and 4th of May, which I showed previously. And this is after she had the cement spacer, the explant plus the cement spacer inserted. Then on the 9th of June is her vac dressing. So at that present time, the skin defect was large, it's about 8 centimeters. As a result, she had further vac dressing before undergoing a split skin graft. So I think just carrying on the story, it doesn't end there. So on the 14th of June, after her split skin graft, we thought she was doing well. So her inflammatory markers had come down and we actually had stopped her antibiotics on the 23rd of July. She had an MRI on the 8th of July and it seemed to be improving. There was a small rim-enhancing subcutaneous collection, but given that she looked to be responding, the antibiotics were stopped. However, in October, she complained of persisting pain and swelling over her knee, and therefore another MRI was done. And this showed actually a fairly large collection now, 6 by 7 centimeters subcutaneous collection over the medial aspect. And this was posterior to the distal femoral shaft. As a result, we took her back to the operating theater. She had another right knee debridement, and this time with arthrodesis and the external fixator. So this time when we took all the cultures again, including mycobacterial cultures, it was negative. But given her history of NTM prosthetic joint infection, and we know it's fairly resistant, she carried on with IV cefoxitin as well as added on IV amikacin, as well as oral clarithromycin. And eventually on the 2nd of May, 2014, she had her right lower limb external fixator removed. So again, just sharing some of the MRI scans. On the 22nd of October, MRI right knee. So the coronal and sagittal T1 post-gadolinium scans. Just sharing with you the 6.2 by 7.6 abnormalities that you can see there on the MRI scan. And at 2014 September, on follow-up, this is her X-ray at that point. And then on the right-hand side was when she had the external fixators in April. So I think we come to the end of the story. So fortunately now, fast forward 8 years, I was just looking at her notes for this webinar, and she's actually now 92 years old. So she's done very well for herself. She's still living alone in a flat. She's still independent for basic activities of daily living. And she uses a wheelchair within the flat, but she's able to stand for short periods doing household chores. So I think, unfortunately, we weren't able to retain her knee, but her functional status is still fairly good. So I think I'm just going to review about NTMs. So we know NTMs are mycobacterium species other than M. tuberculosis and M. leprae. It's environmental bacteria found in soil and water. There's many species that have been identified, which mostly frequently cause pulmonary disease in about 90%. Extrapulmonary NTM disease is less common, about 10%. And the most common manifestations are lymphadenitis, skin and soft tissue infections, and in immunocompromised hosts, there may be disseminated infection. In a review in the US from 2009 to 2014, where they reviewed hospitalized patients with extrapulmonary NTM, the most common found was MAC in 50%, followed by M. fortuitum, M. abscessus, and M. coronae. So we know the classification can be split into rapidly growing mycobacteria as well as slower growing mycobacteria. And we know this is depending on less than 7 days or more than 7 days. And the most common species are listed up there on this table. So in terms of commonly identified pathogens in prosthetic joints, the most common ones are listed here. So usually Staphylococcus aureus, as we know, coagulase negative staphylococcus, as well as streptococcus. And the different time periods, infections, mostly Staphylococcus aureus and coagulase negative staph. And we know also in prosthetic shoulders, then we worry about propionibacterium. And then there's also a fair proportion, about 10% or 14%, which may be culture negative. Generally, NTM is a rare cause of PJI. Less than 1% of cases have been diagnosed with NTM. In a retrospective single institutional review at the Mayo Clinic, over 37 years, they actually only identified 8 cases of rapidly growing mycobacterial PJIs. So actually most of the understanding of NTM and PJIs come from case reports, as well as limited case series, and also review of the literature. So I think just going through some of the available literature, again, depending, there will be a reporting bias. So this was done by Henry et al. So case report of 2 patients and a review of the 43 rapidly growing mycobacterial PJI in 41 patients up to 2016. The age on general was 65 years old, but there was a large range from 26 to 87, about half female and half male. Of the reported provided underlying medical conditions, actually the majority did not have any specific underlying medical risk factor. 4 had rheumatoid arthritis and 3 had intra-articular injections. In terms of indication for joint replacements, 28 degenerative joint disease, 4 was rheumatoid arthritis, and 4 had traumatic fractures. In terms of time to onset of symptoms, about half actually presented fairly early, like my patient. So 46.5% within 12 weeks, and then 65% within a year. And then at 2 years, about 67%. But there were some outliers. So there were 5 who actually presented more than 10 years after their initial joint replacement. In terms of location of PJIs, unsurprisingly, 23 knee, 18 hip, 1 elbow, and 1 trapezium. And in terms of the microbiology, the majority was actually M. fortuitum that was reported, M. colonae, as well as M. abscessus. And the clinical presentation was fairly variable and fairly difficult to differentiate from routine bacterial infections. So it can range from chronic localized hip joint infections with fistula formation and extensive soft tissue abscesses to quite acute presentations as well. So there was actually another Thai series, which actually looked at a retrospective case control of PJI hips or knees in a tertiary hospital in Bangkok, Thailand. And this is over a 12-year period until 2012. They looked at 178 patients in total, and they actually had 16 mycobacterial PJIs, of which 5 were TB, and the 11 were rapidly growing mycobacteria. The characteristics, when they did compare the non-mycobacteria and the rapidly growing mycobacteria PJIs, there wasn't actually much difference in their characteristics, the age, the comorbidities, indication for joint replacement, immunosuppression, even the way they presented, whether with pain, loosening of the joint, sinus, or fever. Investigations, white cell count, ESR, and CRP were not significantly different between the 2 groups. Of note, I think most of us would not suspect it or expect it. So it's not surprising that initial antibiotics was inappropriate in all of the mycobacterium PJI group compared to those who were with the regular bacterial PJIs, where they received about 50% received appropriate antibiotics. They did mention that a low index of suspicion and negative routine cultures could be the reason why they didn't receive appropriate initial antibiotics. In terms of comparing between the 2 groups, they did find in this particular case series that non-mycobacteria rapidly growing mycobacterial PJIs, infection within the first 90 days of the arthroplasty was significantly associated with rapidly growing mycobacterial infections. So with a high odds ratio of 21. So they postulate for this particular case series, it may have been related to intraoperative contamination, although further infection control investigations didn't reveal additional concerns. In terms of management, as you could imagine, it's so varied. What we know is from single case reports as well as review of the literature. So again, going back to the case series that was shared earlier, we can look at 2-stage exchanges that were done. 16 were cured and not on antibiotics. Some had reimplants but remained on chronic suppressive antibiotics. Interestingly, the average duration of treatment after removal of the initial operation was about 4 months. Shortest duration was 3 weeks, but on average, most were about 3 months. There was also resection arthroplasty. So 15 had resection arthroplasty and were not given antibiotics. Some were because they were on palliative care. In terms of retention, actually most of them, all of them were on chronic suppressive antibiotics, and they also had discharging sinuses as well. In the Thai case series, they found that implant removal was associated with improved outcomes at 6 and 12 months. So it does appear that implant removal is crucial for management. There is a operative interventions and outcomes practice shared by the University of Colorado Hospital, and they work closely with the National Jewish Health, which is a renowned center for NTM infections and treatment. And there they actually have a protocol where infected hardware is removed in all patients with PJI. Then they put in a temporary articulating prosthesis with antimicrobial loaded PMMA cement. And then after several months of antibiotics, they will be replaced with a permanent prosthesis. So this is just some antibiotics that were shared for different types of mycobacteria. So you can see, depending on what mycobacterium was isolated, from a review here of extrapulmonary NTM infections, this is some suggested regimens. So you have amikacin, duloxetine, imipenem, and tigecycline. And generally, it's a combination antibiotics followed by oral antibiotics for several weeks to months. So I just summarized it here, that antibiotic therapy, a variety of approaches. In terms of, I've just written out all the different combinations used. As you can see, there is no fixed pattern, and everyone had a variable approach to treatment. So you can see it's usually a combination of resection arthroplasty followed by multiple drugs, followed by reimplantation, and some followed on with antibiotics after that. So I would say in summary that a multi-drug antibiotic therapy is usually used, determined according to the antibiotic susceptibility in the organism identified. Where possible, removal of all infected tissue, including the implant, is required, and then repeat revinement may be needed as well. Slow-growing mycobacterium, just one slide, just to say it's been exclusively reported in immunocompromised patients rather than immunocompetent. So they seem to present differently. And lastly, just to share, the outbreak of NTM PJIs in Oregon, USA was thought to be associated with a particular brand of prosthesis, as well as the vendor presence inside the operating theater during surgery. So something to think about if we do see a clustering of NTM PJIs. So I think my last slide, take-home message, it's rare, less than 1%. Clinical presentation and patient characteristics may not be so different from bacterial infections. Yield of routine bacterial culture is low. Multiple specimens should be sent, and you could consider it if your initial bacterial cultures are negative. For rapidly growing mycobacterium fortuitum, chelonae, and abscesses seem to be the most common and in immunocompetent patients. Implant removal is associated with improved outcomes. Multi-drug antibiotic regimens are usually used, guided by susceptibility. And there was some suggested approaches using two-stage exchange, resection arthroplasty, followed by antibiotics, and then a reimplant. And just be aware of nosocomial outbreaks, and that slow-growing PJIs seem to occur most exclusively in immunocompromised patients. Thank you. So I would come to the end of my presentation, and just a photo of my hospitals where I work in Tan Tock Seng Hospital at the top, as well as the National Center for Infectious Diseases. And I thank you from Singapore.
Thank you, Monica, for this very nice and comprehensive review and presentation. There are two questions from Isoto Sa. One of them is asking about, other than colony pigmentation and morphology and growth rate, are there any advanced diagnostic tests for NTMs? And the other question is from the same person, says, are there antibiotic alternatives to treat such infections? Perhaps you could comment, or maybe Matthew could comment in his talk.
Yeah, thank you so much. So I think for the NTMs, it does appear to be, as you said, repurposing antibiotics. We know that it's usually a combination. So we use azithromycin, clarithromycin, cefoxitin, imipenem. We've been using tigecycline, clofazimine as well. Sometimes here in Singapore, we've looked at linezolid as well as tadalafil, and we've also used amikacin, tobramycin, and there's been some interest in bedaquiline as well. So I think it's fairly complex, the treatment of NTMs, because as you know, it's a difficult to eradicate organism, particularly for the M. abscesses. So it usually requires a multi-drug regimen. Hopefully there will be more drugs that we can use because the current drugs are not so targeted towards M. abscesses. And we have been struggling actually quite a bit with NTM pulmonary disease, for example, M. abscess lung disease, in terms of antibiotics that can be used.
And advanced diagnostics, mostly PCR? And
so I think within within Condoxing and within Singapore locally, we actually do have some molecular testing for NTMs just to the species, but still in investigational or research sort of arena, and we don't use it routinely. So we send it to, mostly for our skin and soft tissue, we have sent it to our National Skin Center, and they have done some PCRs for us for NTMs. Thank you.
Thank you. So I think
So I would like to present Matthew Dryden. He's an old friend that we started together as a pioneer with this working group, and his talk will be on treatment of skin and soft tissue infections with reactive oxygen. It's very interesting. Please.
To give an overview on my recent research interest into reactive oxygen in skin and soft tissue infection. Now, you can see on the right of this slide the projection for deaths due to antimicrobial resistance compared to other diseases, and it's projected to increase dramatically over the next few decades. So we have a global antimicrobial resistance crisis. There's limited antimicrobial stewardship in skin and soft tissue management. There's a huge burden of disease in terms of chronic wounds, many of which are colonized with bacteria, some of which are multi-resistant. And there's the issue around biofilm in skin and soft tissue as well. There's some debate over the most effective topical agents and how to manage these difficult and complex wounds. So what is reactive oxygen? Well, it's a fairly simple concept, really. It's a combination of a mixture of carbohydrates with enzyme, which in the presence of water get broken down enzymatically to release oxygen radicals, which themselves are then antimicrobial with anti-biofilm efficacy. And there's some evidence that they are effective in wound healing and wound regeneration as well. So complex carbohydrates plus enzyme plus water. And there's a fair bit of data looking at the physiological activity of reactive oxygen, starting in the bottom left here with hemostasis, then supporting immune modulation and the attraction and migration of immune cells. There's some evidence that reactive oxygen plays a role in tissue repair, but my initial interest was that reactive oxygen is highly antimicrobial. And this is one of the first papers we published a few years ago, looking at the spectrum of activity of reactive oxygen. And really, in contrast to regular antibiotics, oxygen radicals kill really the whole spectrum of bacteria, even, we believe, atypical mycobacteria, referring back to Monica's talk. And this just shows some of the diffusion. Initially, reactive oxygen was held in a honey carrier, but it doesn't have to be related to honey. But in these photographs, we compared the reactive oxygen honey, Sergi honey, with other medical honeys. And you can see the huge zones of inhibition to both gram-positive and gram-negative bacteria, even if they were highly resistant. So here we've got E. coli, MRSA to the right, Group A streptococci in the bottom, and Pseudomonas aeruginosa. Beyond that, reactive oxygen seems to have a very rapid and prolonged cidal activity when it's released slowly and persistently by enzymatic activity. So it was in our paper looking at the time kill curves against MSSA, VRE, MRSA, E. coli, and Pseudomonas aeruginosa, with the S of Sergi honey and another S substance is the reactive oxygen product. And you can see here the rapid log reduction in bacterial load that persists over many days. More recent data from the lab in Porton Down has looked again at synthetic reactive oxygen. So this is not Sergi honey, this is synthetic agent against MRSA on the left and a highly resistant Acinetobacter baumannii on the right, again showing rapid cidal activity which persisted over many days. But the mechanism of action, I think, is several-fold. It's partly osmotic because you've got a high osmotic level of mixed carbohydrates, but also the enzymatic activity seems to totally disrupt the cellular structure of bacteria. So here we've got a strain of MRSA pre-treatment, 15 minutes after exposure to RO, and then 30 minutes down the bottom right. So the cells are completely destroyed. Another very interesting feature, I think, related to reactive oxygen, which I think applies to chronic wounds, but in this case, this particular experiment carried out by Ray Allen in Southampton University looks at a respiratory mucosa model. So it's still soft tissue, but it's respiratory soft tissue. And it shows that reactive oxygen is cidal in the presence of biofilm, unlike antibiotic. So in the B picture here, you've got green growing cells of Haemophilus influenzae on the biofilm without any intervention. In the next picture down, C, you've got biofilm exposed to coamoxiclav, and the coamoxiclav antibiotic is not able to penetrate the biofilm or kill the bacteria. There's a lot of green there. But with reactive oxygen in the picture D, most of the cells are destroyed. So it looks like reactive oxygen is helpful in biofilm. Excuse me. In addition, there is some evidence from various papers, of which this is one, that reactive oxygen may be helpful in tissue regeneration, that it plays a physiological signaling role in the growth of tissues. And in this experiment, a unfortunate tadpole has had its tail amputated, and oxygen radicals, RO, are required for the regeneration of that tail. So tissue generation as well. Now, thinking about it, if you look at a lot of infections throughout the body, there's a huge disease burden in biofilm-related infections, not just soft tissue, including chronic wounds, ulcers, and so on, but also respiratory mucosa with chronic sinusitis, ENT infections, chronic respiratory disease, and bladder mucosa as well, chronic recurrent cystitis. There's also prosthetic material throughout the body, as depicted in this chart on the left here, and reactive oxygen may play a role in the management of that in the future. So the key characteristics really of reactive oxygen treatment is that currently it's topical treatment, but that's not necessarily a bad thing because it can be an adjunct with systemic antibiotics, that it is highly antimicrobial, it's potent in biofilm, and it's tissue healing. So this shows the sequential photographs of a patient with a chronic venous stroke ischemic leg ulcer, heavily colonized with Pseudomonas and other resistant organisms, and the treatment over the course of a few days in clearing the biofilm, the bacterial burden, down to a nice granulating ulcer, which will hopefully heal. There's limited but not randomized controlled studies of the management of soft tissue infection with reactive oxygen. And this is one paper looking at the anecdote, so it's an anecdotal paper, an observational paper, looking at the response of various chronic wounds to treatment with reactive oxygen. And this paper showed that there's a reduction in bacterial load in virtually all the wound types. There's a reduction in the wound size and an improvement in the variety of healing criteria, so discharge, slough, and inflammation. And I'm just going to show a few clinical pictures now of where we've used it in our clinics or in our patients, just to show you some of its clinical applications. Here's a young lady with recurrent community-acquired MRSA impetigo from various ear piercings carried out in a full moon party on the beach in Thailand, where she's acquired this rather pathogenic strain and it's caused repeated infection. But you can see a reduction in the lesions over time. Another young person who'd been in a road traffic accident with nasty excoriated soft tissue and bone fractures, but you can see here the potential for these colonized soft tissue lesions to cause osteomyelitis by passing down through the external fixators. But Surgery Honey prevented that. This patient was a traumatic wound in India, and when returned to the UK had a variety of mixed organisms in his soft tissue, of which almost certainly the predominant pathogen was group A strep, but there was also MRSA there and a variety of multi-resistant gram-negatives. And he received management with debridement, had narrow spectrum antibiotic prescribing, really just to target the group A strep, topical reactive oxygen and skin grafting, and he did very well, and the resistant organisms were cleared. It has antifungal activity, and this is a small boy who had a fungal carrion on his scalp with Trichophyton tonsurans. He was not, he refused any oral antifungal treatments, so he was just treated with topical Surgery Honey, SHRO gel, and the fungal infection was confirmed. He received treatment for about a month, and you can see slow resolution of the lesion. We've used it occasionally in infection control issues as well. So this oncology patient was colonized at their Hickman line site with a carbapenemase producing gram-negative, and SHRO gel cleared that colonization and allowed maintenance of the line and continuation of oncology treatment. A neonate with it's difficult to know whether it's infected or just colonized, but this baby had an abdominal procedure for intussusception, and you can see on the left-hand picture, a small granuloma, so mild infection, but caused by MRSA, and just treated with topical Surgery Honey, and that resolved well. So I have a view that this could be very helpful in the future in surgical prophylaxis as well. And so a couple of years ago, we carried out this study in cesarean wounds, for which there is a higher rate of infection anyway. And we use Surgery Honey prophylaxis as a single dose at wound closure. And although, again, this is a very biased study, an observational study looking at infection rates before and after the intervention, there was a dramatic reduction in infection rates in surgical site infection in these cesarean patients. This has also been looked at in a small pilot study in University College London Hospital, looking at abdominal reconstructions with sinuses and intracutaneous fistulae and so on. And they've used Surgery Honey and again at closure of wounds, and have shown a reduction in surgical site infection. In addition, it's been used in other deep-seated structures. This is a group in Wales looking at complex joint reconstruction, and they have used reactive oxygen gel when replacing complex joint infections. Again, with good outcomes in this small group of pilot studies. More recently, we've looked at reactive oxygen gel either nebulized or applied directly in the respiratory mucosa. And on the right-hand side, you can see application of Sergi honey into chronic sinusitis via endoscopic administration. And that was well tolerated. But again, there are no randomized controlled studies for these. And during the COVID outbreak on ITU, we've had several patients who've had post-COVID complex ITU admissions with heavy bioburdens in their respiratory tract, sometimes with secondary infections and abscesses. And we've used nebulized reactive oxygen gel in these patients to reduce the bacterial load and clear the multi-drug resistant bacteria. So in summary, I think this technology is very interesting. RO shows rapid cidal activity, including all the resistant organisms we can test it against. It has biofilm penetration and may be involved in tissue regeneration and immune stimulation. The Sergi honey, the honey-based one, is licensed for use in the EU for chronic wounds and soft tissue, but there is a synthetic version being developed by the company as both as a gel, a dry powder formulation, which could be poured into wounds, and perhaps being combined with other matrices for deeper application. So in the short term, I think we need to develop the evidence base around the use of RO in soft tissue infection, but I'm particularly interested too in preventing of surgical site infection. In the longer term, I think RO can be used for a variety of perhaps more deep-seated infections, but time will have to tell on that. Thank you. I'm going to stop there. I hope I haven't overrun my time. Thank you, Silvano and Corday.
Thank you so much. Thank you, Matthew. Thank you so much. I don't know if there are some questions. Maybe, Corday, do you know if there is a question for Matthew?
Matthew, thank you. There are numerous questions and comments, actually, but one of them is, what about its application in burns? And there are a few comments about the challenge that clinicians face when they do research on chronic wound and ulcers, especially in diabetes. Often etiologies are different, the time point are different for researchers. So what are your comments on these and how you could, almost like a study, how you study Sergi honey in this situation or reactive oxygen in this situation when it's really challenging?
Those are all interesting questions. Thank you, Cordo. We've used it in minor burns, but we don't have a burns unit in our hospital, so I've not tried it extensively, although there has been some interest in other burns units in the use of RO. And I think it ought to perform very well in that situation because you often have multi-resistant organisms forming a biofilm, and RO ought to be able to reduce the bacterial load and promote tissue healing. So I think a study is required there. It's absolutely right that it is very difficult to study chronic wounds, which is why I was preferring to develop a randomized controlled trial in surgical prophylaxis, which is much neater. And of course, the group that we used, women with cesareans, are otherwise healthy by and large, and yet there is a high rate of infection. So it seemed a very useful study population to look at. But with chronic wounds itself, we have that observational study that is published, which really, all we could do was monitor wound size, extension of infection, bacterial burden, and so on. But I agree, it's very, very difficult to study chronic wounds.
Yeah, and we have in some places they use honey as a treatment, topical treatment. Just a comment: are all honeys equal in their antimicrobial activities?
No, I mean, that's a good question as well. No, they're absolutely not. Obviously, Manuka is highly antimicrobial and works by a different mechanism from reactive oxygen. Some honeys are hardly antimicrobial at all. Others are very antimicrobial. But really, I think one has to standardize it. And that's ultimately why a synthetic version, I think, is probably the best bet.
Yeah. And finally, why not hyperbaric oxygen compared to reactive oxygen? What's your opinion?
Yeah, I mean, I've not personally practiced with hyperbaric oxygen, but I think the principle there is to force oxygen into the tissues by high pressure, and I guess it's probably working under the same system, same mechanism that you're getting oxygen radicals into the tissue, which become antimicrobial. Slapping on a gel is much simpler.
Thank you, Matthew. There are other comments and questions, but for
perhaps they can be forwarded.
Yeah, for the sake of time, we would forward those to you.
Thank you.
So now we will move on with our webinar, and it's a pleasure to introduce Dr. Pasquale Pagliano from University of Salerno in Italy to talk about the Italian registry in management and epidemiology of skin and soft tissue infection. Pasquale, please, over to you.
Thank you to Professor Saeed and to Professor Esposito for their kind invitation. Here we report the final data on the Italian National Registry on skin and soft tissues infection. We know that these infections are increasing in terms of burden. As you can see in this paper, the total incidence is increased from 85 to 105 cases for 10,000 persons during the 12 years period. But what we see, excuse me, what we see is that the highest burden of disease is observed in older adults that quite double their incidence during the last time. This is associated with an increase in terms of total prescription, of total burden of direct cost, and in terms of antibiotics prescription. If we see this data that are from a study that collect both patients from ambulatory settings and inpatient settings, we can see that the manifestation and the complication related to this disease is different in these two settings. And patients that are observed as inpatients present frequently complication and present manifestation like abscess, cellulitis, or surgical site infection, decubitus suture, that are not seen generally in ambulatory settings. So we aimed to investigate which is the role of the ID specialist in a real-world settings of inpatients as assessed by the analysis of our national registry. 29 centers were involved in this study, as you can see, in all the region of Italy. And totally, we collected the data on 478 patients. Male to female ratio was 2, and the patients were enrolled during a 3-year period starting from January 2017. This is the age distribution. As we can see, patients, most of them aged between 40 and 70 years. Median age was 71 years, and average age was 60 years. And if we compare our demographic data with those reported by other authors, we can see that this is quite similar to the findings reported by other studies that investigate patients admitted to hospital. But this is different than other studies that consider also ambulatory settings. And in these cases, the median age or the average age was lower. If we see the setting of a consultation, our ID specialists mainly were worked in ID department, but also in the internal medicine department and the surgery department, they work as a consultant. Here is the duration of symptoms prior to first ID consultation. This was at the median of 6 days and an average of 16 days. We saw a very wide range of in the time between symptoms, evidence, and ID consultation. This is the slide that reports the SSTIs diagnosis. As you can see, cellulitis, erysipelas, surgical site infection, or diabetic foot infection, venous suture infection were observed with the highest frequency, and this is consistent with other study. As we see here, the study by Miller that we have already seen, the study by Garau that consider inpatients as our case series. And we see a lot of patients with cellulitis, cutaneous abscess. We distinguish erysipelas, but I think that in the other study, this is not considered. This is considered within the cellulitis cases. We have an important number of surgical site infection that is lower than reported in the study by Miller. And 99 cases fulfilled the criteria for acute bacterial skin structure in infection, as you can see here, and the localization was mainly in the lower limbs of the patients. If we compare this data with those reported by Gibson, we have quite similar data. If we look at the comorbidities, we see that cardiovascular diseases and diabetes were the comorbidities reported with the highest frequency, and it is relevant, but we expect this. That diabetes has an incident that is about 6 times that retrieved in the general Italian population. Here is the comparison with the other study on the argument, and we can see that there is no difference in the study by Garau, and there is a difference with the study by Chain, but we know that this study collected data both from ambulatory and inpatients settings. The infection reported in diabetic patients are mainly diabetic foot infection, but we have to remember that also cellulitis or a reciprocal surgical site infection can be observed mainly because of the predisposition that these patients have to this sort of infection, to skin and soft tissues infections. So we tried to investigate which is the microbiological approach to SSTIs in the real life setting. And as expected, 28% of the cases did not receive any microbiological examination. Most of the cases of these cases were cellulitis. But if we see which microbiological examination has been performed, we can see that superficial swab, blood culture, deep tissue cultures were performed with in the majority of the cases analyzed. Only 213 cases had a positive culture, and these had monomicrobial growth of bacteria and polymicrobial growth in 83% of the cases. Comparing this data with those reported by other authors, we see the same as for the other items. So when you have an ambulatory setting, we have a lower number of microbiological examination than you have when you see the patients as inpatients. Also, microbiological examination were comparable for the microbiological examination were similar in our study, in the study by Garau. This is the rate of positivity of each examination. As we can see, the superficial swab was negative about in 18% of the cases, and the blood culture were negative in the about 60% of the cases. But this is generally consistent with the data reported in the literature. We have to see that deep tissue culture, biopsy culture, had positive results in many cases, and we know that these are the most frequently performed examination in these cases. Looking at the bacteria species isolated, we see gram-positive bacteria in 60% of the cases and gram-negative bacteria in 32% of the cases. Staph aureus was isolated in quite 37% of the cases, and as we can see on the right part of the slide, about 50% of the cases reported methicillin resistant. If we consider gram-negative bacteria, Pseudomonas aeruginosa is the bacteria that is isolated with the highest frequency. This is the comparison between our data and those reported by the other authors. We report a percentage of gram-positive that is similar to that reported by Garau, but is lower than reported either by Ray and Tiwari. But Tiwari report a study mainly on surgical site infection, and Ray consider ambulatory settings. Now we have tried to see which is the impact of ID consultation on antimicrobial therapy. Before our consultation, only a part of the patients received, only 60% of patients received an antibiotic treatment. This treatment was done mainly by an oral antibiotic. There was, as expected, right, failure rate, but is related to the fact that a consultation has been asked. And if we see which antibiotic these patients were receiving, we can see that prior to ID consultation, patients did not receive an anti-MRSA treatment as suggested by current guideline, either if we consider patients receiving monotherapy or those receiving polychemotherapy. After ID consultation, here we can see that in many cases patients received an association therapy, and in many cases the intravenous route was adopted. The duration of the therapy was between 4 and 14 days in about 70% of the cases, and an improvement was observed in the large majority of the cases receiving treatment. Here we can see which drug has been proposed for these patients, and we can see that the number of cases receiving an anti-MRSA treatment is very, very higher than observed before. Either if we consider the patients receiving monotherapy or those receiving an association therapy. The duration of therapy was 11 days as average 10 days as a median, as suggested by the current guideline on the argument. So concluding, we have to say that cultures are not performed in about 1/3 of the cases, and the specimen collected report bacterial growth about 60% of the cases. But if we collect the correct sample, we have growth in over 80% of the cases. Gram-positive strain is isolated in the majority of the cases, but in more severe cases, we have to consider that gram-negative strains are frequently present. The problem is the anti-MRSA coverage that is not currently provided prior to ID consultation. Thanks.
Thank you, Pasquale, for your presentation. Clearly, a huge amount of data, which is really great, and I hope to be published so that we all look at it more thoroughly and
trying
globally. Yeah. There are a few questions or comments. One of them says, basically, I summarize it. Do you have any opinion about using Aaron or CREST classification for determining severity, and also could they lead to over or under treatment?
We had a very high burden of data, and we are analyzing this. So we are analyzing the severity, the contribute of ID specialists in respect to the severity of the case. But most of these cases were severe cases, because of as a general aspect, the patients are treated before by other specialists, and then they arrive to the ID specialists when they have a problem and unresolved soft tissue skin infection.
And what classification for severity do you use? Do you use Aaron or CREST classification, or do you have your own classification?
Your audio went away. Can you repeat?
Do you use Aaron or CREST classifications for severity, or do you have your own classification in Italy?
No, we don't. We are analyzing the classification in respect to severity. Okay.
Actually, do you believe that Aaron is still effective for classification of severity? Are you still using it in England?
This is for
we don't actually. We don't. I mean, the British Society recommends it, but you don't. I think it's really challenging in these situations, especially when you have patients who are septic. I mean, Aaron classification doesn't account for that, so it can be really challenging. So we do it patient by patient. When we do a study, when we try to recruit for a study, we stick to these definitions, but in clinical practice we don't.
Thank you. So let's move on to the next speaker. It's a pleasure to introduce the next speaker, who is Nusreen Ahmad-Saeed, and the title of his presentation is Detection of Difficult to Culture Bacteria Associated with Bone and Joint Infection Using Real-Time Polymerase Chain Reaction.
Hello, everybody. Thank you so much for that lovely introduction. I am going to spend the next 10 minutes or so just quickly telling you about an area of research that I'm particularly interested in, that has taken up a large proportion of my life in Southampton and has formed the basis of what was my PhD. So I have spent the last few years looking at bone and joint infections, specifically in children, and looking at better ways in order to be able to diagnose bone and joint infections. We know that in the UK, it is often very difficult to be able to diagnose using conventional culture for a variety of different reasons, including the presence of viable but non-culturable organisms, and also because of recalcitrant organisms or prior use of antibiotics. But we know that it is essential to correctly target antibiotic therapy so that we can reduce treatment failure, reduce the use of broad spectrum antibiotics, and shorten hospital stay by switching to oral antibiotics. So in Southampton, we actually define pathogenic bacteria in about 8% of around 1,200 fluid or tissue samples from sent to us from theatre. So it's quite low. We know that osteomyelitis is infection of bone and joint with viruses or bacteria or fungi. They can either occur hematogenously or through secondary spread. Septic arthritis is infection of bone and joint spaces by bacteria, viruses, fungi, or potentially parasites. Usually occurs secondary to bacteremia and is often accompanied with osteomyelitis in younger children. We know that there are specific organisms that tend to be found in children of particular ages. So, for example, we most often find organisms such as group B strep in neonates. In children under 2 years old, we find organisms such as Streptococcus pneumoniae, Haemophilus influenza if they haven't been vaccinated, and also Kingella kingi. As children grow and as they age, we see a change in the organisms that we see. And in older children, we tend to see organisms such as Staph aureus and occasionally PVL producing Staph aureus, although that is rare in the UK. So we know that there is an urgent investigation and treatment required, and we know that age-related pathogens do vary, and children with underlying immunosuppression can often be quite complex to treat and would need a longer course of antibiotics, potentially intravenous antibiotics as opposed to oral. We don't know, however, how our use of empirical antibiotics can affect patient outcome. We don't entirely always know the correct dose, the frequency, duration, the length of antibiotic therapy, and when to switch from intravenous to oral. So what we need to do, or what we decided to do, was we decided to look at the changing microbial pathogenicity and understanding organisms such as Kingella kingi, which are becoming emerging infections. And we decided to use this in order to be able to look at new diagnostic methods, to move away from conventional culture and move towards molecular diagnostic methods. So we wanted to produce a diagnostic test that was quick and accurate. And we decided to do that using real-time multiplex PCR. We developed 3 multiplexes. The first one contains Kingella and group A strep and an MS2, which is our internal positive control. Our second multiplex contains Salmonella, Staphylococcus aureus, and Staphylococcus epidermidis. And our third contains group B strep, Haemophilus influenza, and Streptococcus pneumoniae. Each of these multiplexes contains primers and probes for each of the target organisms. Each of the probes contains a different fluorophore to allow each of the organisms to be identified independently of the others. So just having a quick look at some of the data that was generated from all of this research. This table really just shows the number of positives that we identified for each of the target organisms. This is based on patients. But the thing that is quite interesting is when we look at the age ranges that we see here, we do indeed see that organisms such as Kingella, which we have seen in a previous slide, do tend to affect children under the age of 2. And here we can see our median age is 1.2. Likewise, we know that Staph aureus is more common in older children. And again, our median age is 13.3 years. So we can see that there is some correlation with what is published to what we have actually seen locally. When we compared the results that were generated from our PCR tests with conventional culture, we identified that there were 14 samples that were positive both by culture and by PCR. However, there were 102 samples that were negative by culture but were positive by PCR. This is a real game changer, because that means that by being able to identify an organism in that patient's sample, and the beauty with PCR is that you can use it to identify an organism, whether the organism is alive or not. It makes no difference because you're looking for the presence of the organism. It meant that these patients could get targeted antimicrobial chemotherapy. There were 105 samples that were negative for both technologies. And there were 7 samples that were positive by culture, but were in fact negative by PCR. And on further investigation, these were identified to be a coliform and 3 coagulase negative staph other than Staph epidermidis, which is what we look for on our panel, and 3 Pseudomonas species. So this made quite interesting reading and was very, very encouraging for us. When we look at the types of samples that we tend to find with these infections, and I must stress that these are all pediatric samples, we tend to find that the majority of samples that we do get are fluids, so pus or bone and joint aspirates. And that is indeed where we find the majority of our positives. But the one thing that is incredibly interesting in this is that if we look at organisms such as Kingella kingi, we find that in our sample cohort, 33 of our patients were indeed positive for Kingella kingi, whereas for Staphylococcus aureus, we only had 26 patients. Historically, Staph aureus was always thought to be the most common cause of bone and joint infections. However, this presence of Kingella kingi is interesting because could it be that Kingella is an emerging infection, or is it because we are using different methods in order to be able to identify this organism in bone and joint infections? There has always been a lot of thought in adding bone and joint aspirates adding bone and joint aspirates for 2 blood culture bottles in order to dilute out inflammatory cells to give organisms such as Kingella a better chance of growing. That's something that until recently was not very well adopted in Southampton. So it's interesting to see whether or not we actually start to identify more Kingella in the future by culture using this method. So I think that's probably going to be something for the next presentation, hopefully. So when we look at this in terms of diagnostic yield, if we cut to the end first, we see that our diagnostic yield of pathogenic bacteria by culture was in fact 5.7%. So out of 138 patients, we only identified pathogenic bacteria in 7 of those patients. Yet, however, using the bone and joint panel, we have managed to identify pathogenic bacteria in 66.66% of patients, so 92 patients out of 138, which really can make such a huge difference, getting patients switched from IV to oral antibiotics and being able to discharge them home is much better for the patient. They've got a better chance of recovery in their own environment where they're sleeping well and they're amongst their own family and friends. It's much better for them. So this work was actually used in a HTA-funded feasibility trial to look at therapy for children with osteomyelitis and septic arthritis, and it's actually named Project Dinosaur. And here's a little here's the logo up at the top here. So do feel free to Google it if you do have the opportunity. It does make very interesting reading. So the title was The Duration of Intravenous Antibiotic Therapy for Septic Arthritis or Acute Osteomyelitis in the Pediatric Population. And out of all of that, they managed to get the acronym DINOSAUR. Quite how, I have no idea. So just to put this into context, I thought I would add a short case study to the end of this presentation. So we have a 5-year-old child who has been complaining of left ankle pain. It was thought that he twisted his ankle a couple of weeks previously. He presented with a temperature of 37.9, so not particularly high, and with a CRP of 25. When his samples were looked at, he had a white cell count of 10, 7 of which are neutrophils. His left ankle was warm to the touch, but not visibly swollen. The MRI that was performed on him showed osteomyelitis of the distal fibula, and it looked like it had been an indolent infection. So he'd had it for 3 to 4 weeks, even though he'd only actually been complaining of pain for a couple of weeks. So based on that, this is our shortlist based on his age of potential causative agents. And on PCR, we actually identified that he did indeed have Kingella kingi. He was able to be put onto targeted antibiotics, and he was able to be sent home on oral therapy. And as far as we are aware, was much, much better. So, in conclusion, we have managed to develop a specific and reliable assay with results that could be available within 24 hours of the sample being taken, which is a real game changer. It may lower the threshold for operation when not improving rapidly on empirical therapy, and it can potentially shorten hospital stay and assist in switching antibiotic therapy and facilitate the IV to oral switch. It's also much cheaper. It can save up to £100 on 16S PCR and also save on time because we don't perform 16S PCR here. Lots of laboratories don't tend to. They have to send away to externals, and it can take up to a week to be able to get a result. But there are further cost benefits that need to be determined for this use. This panel is able to be used on other cases now, so it is now no longer just used on pediatric patients. It can be used on adults as well, and it can be used on other sterile site infections. So we have actually been able to extend and validate the assay to be able to include other sites such as CSFs and endocarditis samples and so on. And the beauty with this is because this is an in-house assay, we are always able to extend the panel and look at other organisms that could be added to this for the future. And I would just like to acknowledge the following people and thank you all for your time.
Thank you, Naz. In the interest of time, I would just read one question. It says, given the relatedness of Kingella negavensis and Kingella kingi, is your PCR discriminative enough, or is your PCR detects all Kingella or specific for Kingella kingi?
It detects all Kingella. It detects Kingella kingi. What we actually use as our target for this PCR is the RTX locus, which is the toxin that is produced by specifically Kingella kingi. There are other options that are available, but that is the one that we use. There are, as I say, other options, chaperone proteins and so on, that can be used to detect. But this we have found has been the most effective and has had 100% specificity.
Yeah, I'll go to one more question. Says, how you differentiate Staph epidermidis, a pathogen, from a skin commensal? How do you know it's not a contaminant or skin commensal?
Well, in all fairness, I'm not a clinician, so that is not my job. My job is to present the results that are generated and allow the clinician to decide whether or not a Staph aureus positive in a sample is significant. I guess Staph epidermidis, rather, in its ability to form biofilms, is its pathogenicity factor. So, in a prosthetic infection, it is possible that it could be more significant. But as I say, that is not my call, I'm afraid.
So it would be based on the clinical context,
Absolutely,
like any other test. So now it gives me a great pleasure to introduce our final speaker, Professor Parham Sendi, Infectious Diseases in Bern University in Switzerland. Parham.
Thank you so much, Corda, for this kind introduction. I'm going to present the study that has been done in our institution on early switch from IV to oral antibiotics in skin and soft tissue infections. So before I start, I'd like to acknowledge all the people who did the work with this saying here from Peter Agro Nobel Prize. I just didn't do the work. The young people in the clinics did it. I just made the coffee and sharpened the pencils. So this paper is now in revision, and cross fingers that it will be accepted. Thanks to the group here, we can skip the introduction actually, because I have also highlighted the co-authors in this call that already published in 2016 hot topics in skin and soft tissue infection. And if we go there in paragraph 15, there is the saying that it is clear that it should be switched when there is a clinical improvement. And a very nice study cited here with reference 66, which I highly recommend you to read it. But the question is, what does clear improvement means and how can we do it? If we do clinical rounds, we often identify patients and we say that, okay, most cases can be switched, but this study is about implementing it. So when I talk about erysipelas or cellulitis, and I say most of us in our region are caused by beta hemolytic streptococci, then you can easily switch them to orals. But the problem is that implementing it is often a burden. So I'm just going to invest a couple of minutes for the epidemiology, because our epidemiology is different, the one from Italy presented by Professor Pagliano. So in our hospitals, in our regions in Switzerland, we have mainly Staph aureus and beta hemolytic streptococci as the two main causing soft tissue, 90% beta hemolytic streptococci and about 10% Staph aureus. And we hardly have in our region any MRSA. You can see here the resistance epidemiology from Switzerland that has not changed much between 2004 and 2014. We have approximately 4 or 5 MRSA isolates of all Staph aureus isolates, quite low resistance burden. In terms of other antimicrobials in Switzerland, you can see that the majority of Staph aureus is susceptible to clindamycin and other drugs within 10% range. So the Swiss guidelines recommend as a first choice for SSTI amoxicillin clavulanate, and as a second choice clindamycin. So when we did this study, we thought, like, where in Switzerland should we do it? And here I show you the canton of Bern, and there's the region of Emmental. You maybe know the Emmental cheese. And we took 2 rural areas. And why did we do this? Because in the rural areas, we have these young, nice, good-looking gentlemen, but they hate the hospitals and they hate the healthcare. So they only come just prior death. And the first minute they can jump off the hospital, they will run off because they don't want to be. So if we want to treat severe and heavily skin and soft tissue infections and show that we can switch them to oral treatment, these kind of population is the best example to use them. Just another slide about the referral system in Switzerland, so you can compare it with your own community. So usually you have a patient with skin and soft tissue infections. He either goes directly to the hospital, to the emergency department, or he chooses to go first to the family physician. That's his own choice. The family physician is looking at him and thinks, can he treat him orally? And then he will be treated as outpatient treatment. Or he thinks the infection is too severe and refers him to the hospital. The hospital usually then decides again, in 95% of the cases, the patient is in treatment. And if a patient comes directly to the hospital, then again, this decision will be made. And then depending on the severity, he will be treated as an outpatient or as an inpatient. Our study, the study that I'm going to present now, is only focused at inpatient treatment and how fast we can switch them to orals. So in order to save time, I'm just going to quickly fuse some of the results and methods together. So the study was performed within these 2 years. We had inclusion and exclusion criteria that I'm going to present you in a minute. In the intervention group, we said you can have maximum 48 hours IV, but it did not influence the total duration. The non-intervention group had the standard procedure. Usually, at the discretion of the physician, it's between 5 and 7 days. Now, we did not do any randomization. I'll show you why in a minute. And this was a pilot study. So our sample size calculation showed that approximately 900 patients, 450 in each arm, is necessary to show the difference. And you saw in the study by Professor Pagliano that already in whole Italy, during the registry, we had 450 patients. So that was unreasonable to do such a large study. That's why we used for this pilot study only 100 patients in the intervention group. The primary outcome was the proportion of clinical failure. That was a composite definition that either you had new increase in symptoms during antibiotic treatment, or you needed a second course of antibiotic treatment after discontinuing or after switch, or we had a readmission within 30 days, or we had death. And cure, on the other hand, was defined as absence of clinical failure, and all the patients had a follow-up of at least 30 days. So the exclusion criteria you see here, we had in total excluded 28 patients, of course, some non-medical reasons. And then if from the beginning it was clear that it was too severe for oral treatment, then the patient was excluded. These criteria were all predefined prior to the prospective study. You see necrotizing fasciitis, septic shock, and so on. And that was actually the protocol for switching to orals. So you see in the first line that at least one of these criteria had to be fulfilled. The general state improved, that's what the patient said, and what was the impression of the doctor. Pain reduced, erythema smaller. If there was a diabetic foot infection, a reduction of PD4 score, and decrease or lack of increase of laboratory values. I just tell you now, in retrospect, we would remove erythema smaller and decrease of lack of laboratory values. But the last three factors, temperature, enteral absorption, and is able to eat and drink, these were mandatory. And here you see the exclusion criteria. And here you can see that prior switch, one infectious disease consultant had to consult the patient. And if he did not feel very comfortable in switching, then he could overrule it. Again, I'm kind of combining, in the interest of time, results and methods together. So here you can see actually the algorithm. Patient comes in with skin and soft tissue infection. Usually, we see whether he actually qualifies for the study. Here we have an exclusion of about 38 patients that I showed you before. And then after 1 day, they looked whether the patient would fulfill the criteria within 48 hours. The patient had to give 2 signed written consents, 1 for the study in total and 1 for giving the responsibility to the doctor to switch to orals. 127 patients agreed to that. 1 patient refused, but he said he wants to stay in the study. And then the criteria were fulfilled. However, here 6 PIs had, in 6 patients, the PI had cold feet and said like, I don't want to switch this one. This does look a bit, and so on. And this went to the non-intervention group. So in total, we are comparing 97 patients with 31 patients in this prospective pilot study. The results, we had numerous variables. In the interest of time, I'm just showing you the most interesting ones. Of course, you can imagine that in the non-intervention group, you had the more severe cases with the more risk factors. So in the non-intervention group, the body mass index was about 10 kilograms per square meters highest, and we had more frequently patients with diabetes in this group. The study population, if you compare it, it shows more or less the same than the Italian registry studies, with one difference. In the non-intervention group, the more severe group, actually, you had actually 90% just the lower limbs, while in the intervention group, you had about another 15% that were all over the body, in comparison, similar to the data by the Italian registry study. To the laboratory values, and this is actually the most important part actually for the people working in the same hospitals. Number one is you can see that you can switch actually your patients to orals even when the CRP is around 300 to 350, which is frightening, but the patient is doing better. The white blood cells is quickly going down. Be careful, these are the measurements, these are not the days. So measurement 1 was at day 1, measurement 2 was just the second lab, measurement 3 was the third lab, measurement 4 was the follow-up. We did not want to interfere with the physician's decision when to make a lab due to cost reasons. Second most important thing is that if you compare actually the first lab with the second lab, you have more than 50% of patients that show an increase in CRPs. So an increase in CRP in the decision-making to switch from IV to orals is a bad predictor. Actually, you should not look at the CRP, you should look at the patient's state, how is he feeling, and whether temperature went down. The outcome results, we had very few failures as expected with this entity. So we had about 5 failures in the intervention group, and we had 1 failure in the non-intervention group. The total treatment duration was not affected, as we said. Nonetheless, there was a difference. The interquartile range is quite similar to what Professor Pagliano showed, but the intervention group was treated shorter, and the hospitalization duration was even shorter, 5 days versus 8 days in these 2 different groups. Of course, as every prospective study that has a pilot study that is has some limitation, the enrollment was slowed down because of COVID. The algorithm led to an uneven distribution of cases, although that was intended. We wanted to find out those patients that are severely enough to be hospitalized, but still good enough to be switched early. As I said, we did not do any randomization. The sample size in comparison with 100 in the intervention arm is a bit small. A non-inferiority treatment would require more than 100 patients in the intervention arm. I'm sorry, more than 900 patients. We measured the size of erythema, that has a bias, of course. We measured the pain intensity, that is subjective. The decision to overrule despite fulfilling criteria in these 6 patients was also a bias. And in the follow-up phone call, there may be a potential recall bias. Some of those limitations have been raised by the reviewers of our paper, so that's why I'm listing up there, in case one of you is the reviewer. In conclusion, our study showed an algorithm based from switch from IV to oral antibiotics after less than 40 hours of treatment. It could be applied to about 75% of the study population that require the hospitalization. We will adapt our algorithm because CRP and the size of erythema are not useful criteria. The concept was successful in more than 95% cases, and we had a significantly shortened median duration time of hospitalization. None of them is new. All of that has been published already. The main purpose was to implement it. So I thank you for your attention.
Thank you, Parham. Parham, one question I might have missed. Was there any difference in duration of treatment between the 2 groups?
Yes, so the intervention group was treated 5 days, 3 days shorter in the median.
Amazing, amazing. Yeah, I mean, it's great. I would be happy with only 6 individuals to overrule the protocol. So out of 127 was that? So that's a great success.
I'm more than happy to share actually that protocol for all hospitals, because it's really to implement, and you just need the courage when you see that the patient is doing better and the blood cultures are negative. And despite that, you know, the leg is red and the CRP is 200, you just need the courage to switch.
Yeah, and I'm glad you said you, in retrospect, you remove the erythema, because what we find after starting treatment, that the leg could look redder, and that's a natural process of healing and release of toxins. So I agree. There's a question says, what's the oral antibiotics used and the dose for the study?
As I showed, the first choice in Switzerland is oral, is amoxicillin clavulanate, first intravenous, then switch to orals. The dose is in normal renal functions. First, 3 times 2.2 grams for 48 hours, and then we switch to 3 times 1 gram just to cover Staph aureus. We don't need such high doses to cover beta hemolytic strep. And if we use clindamycin, it is 600 milligrams 3 times daily. And if the patient is above 120 kilos, we use 900 milligrams.
Thank you. I can't
Thank
see.
you. Thank you for sharing your data with us. And thank you for citing so many times our registry.
Happy to do so.
Hello?
Silvano, we could hear
so we
you.
go. Do we go on with the conclusion?
Yeah, I mean, it's been a great day. Yeah, it's been a great day. I don't know if Matthew's still online, because there's one question for Matthew.
Yeah, I'm here.
Matthew says, can you use reactive oxygen in breast implant infection?
Yes, we've used it in some cosmetic surgery, and there's obviously a higher risk if you've got to keep the prosthesis in breast implant infection in place. But if it's a fairly minor wound infection, it's worth a try, and it can be used, of course, as prophylaxis in breast implant surgery as well. Thank you.
Thank you. Silvano, there are no more questions.
Okay, so I think it's time to conclude. I want to thank all the speakers. Thank you very much for participating in this, I would say, very interesting, very beautiful meeting. We were discussing the wide range of topics concerning the bone and skin soft tissue infection, ranging from atypical mycobacteria till the experience of our colleague from Swiss, which is extremely interesting. And once again, thank you for sharing your data with us. But also the data from Matthew, I knew something about that because I know Matthew Dryden, and I know that there is a culture of this experience and these topics, but it's always very interesting. We have in Italy, we have very little, maybe no experience about this kind of therapy, and we should approach and to learn more and more. And so once again, I hope that was interesting also for other participants. And finally, if there are participants online, I would invite all of them to take part to our working group. Everybody can be in touch with the Secretariat of the International Society of Antimicrobial Chemotherapy, and they can be in touch with the secretary and ask on how to be member of our working group. Thank you very much again, and I hope to see you again soon. Bye-bye.
Bye. Thank you, everyone.